Good afternoon to everybody. We will try to spend the next few hours now making your time worth spending in here instead of staying at the tapas bar that Frank mentioned. And we will talk about basically all topics of immediacy. We will try to cover from the small areas to the big areas, from the single teeth to the full arches. My topic today will be immediacy in the aesthetic zone, and I will be talking mostly about, case selection, and a little bit about how we do this and how we would proceed on doing it. So let's see if we can change some slides. There's probably some technical issues, but that's the topic of what I'm going to talk about. So planning for success, using digital workflow, and also trying to implement this into a minimally invasive surgery in our patients. There we go. So what are the needs of our patients? At least I'm coming from Norway, which is far up in north, but it still is basically the same need, I think, as the patients in your countries. Our patient is not in need of a new implant system. Neither are they in need of a new prosthetic connection. They're basically not in need of another implant surface. All our patients are in need of solutions. It's the solution that provides a better treatment, a more efficient treatment, and a more minimally invasive treatment. Because if we put ourselves in the chair of the patient, we always have to consider how much treatment is necessary to be done to achieve a predictable result. So if the solution comes out to being, I'll replace your tooth, very often the problem starts with, I'm going to lose one tooth, or I have lost a tooth. The clarifications coming from the patients will be, how are you going to do it? What does it cost? When you're going to do it? And how much time do I need to spend in your office? And how many surgeries do I have to spend time doing? And all those clarifications will, in the end, in a competitive market where patients will be informed enough to choose, make a difference in your clinical life. This is a Monday just before summer. This beautiful young lady comes into the office, smiling, but not smiling. And she's even a colleague of me in the office. And this is Monday morning, so she comes in 10 minutes ahead of her starting time at work. Lost one of her central tooth. And I reckon to be the people that I work with, I tend to look upon them as my family. So I will do the best choice that I can do for her as I would do with my family. And that's basically what we should do with our patients. So what are the choices to do with these cases? How can we treat this young lady and restore her normal function and her normal aesthetics in the most efficient way and the most predictable way, and basically with the best aesthetic result in the end? And we have a big toolbox. It's not like we're not doing 2 hours now to make everybody do everything immediate. We're trying to implement some ideas on some of your cases on how to treat them a little bit more efficient from the patient perspective. So the choices in these cases will, of course, they will depend on the information you can collect from these. And as you see on this case, you will have a high smile line. You see the case has an old trauma, so you see a reduced dimension of the roots. There was done a prosthetic restoration on this central 6 years ago. And when that was fractured now before summer, my question to my colleague was, do you want me to bond it back on? Because basically we can bond and see. And her answer to me was, I haven't been chewing on the tooth for 6 years because I was so afraid of it. To me, that's a disability in chewing. And I asked her, what do you want? You know, you perform these treatments, you know the patients, you know the perspectives. And she says, I want an implant. And then we look into how can we give you the implant? Or how can we give you a tooth on top of the implant, basically. So the considerations that we do when we pick and choose cases on the different treatment protocols will be teeth position. Is it important for the patient to have an immediate restoration? In the aesthetic zone, yes. In the posterior zone, maybe not that important. It's all about weighing up the benefits and the risks. Gingival margin is important. You're not gonna obtain a better gingival margin It looks like that when you do immediate procedures. Buccal bone needs to be in place, and we'll go through those factors. The position of the root within the alveolus or within the jaw is of utmost importance. The chance of obtaining primary stability is there. I will talk a little bit about what are the prerequisites to do so. And also occlusal control. We need to control whatever loading or forces that could be applied on a potentially temporary restoration. So let's go in to see how would I consider this one. This is a cone beam CT of my colleague, showing that we do have a gingival margin which is favorable. There is no gingival recession compared to the contralateral central. And that is important. That is one of the key, basically one of the key determining factors of when to go for immediate restoration in my practice. There's also bone buccally, as you can see. So there's intact bone buccally, and you can see the position of the root. That's why we always need to have these cone beam CTs when we do immediate procedures. We cannot guess. We need to know, is it a class 1, 2, 3, or 4? And if you started doing these procedures and you think that everybody's class 1, it's just a matter of time before you do your case number 9. And that's going to be a class 4. And your drill is out in the palate. And those of you working in these techniques know that that happens if you don't get the necessary information. So we have all of that information. Then we look to facial bony classification, or the bony defects. Is there a bony defect that will limit the potential of placing an implant at the time of extraction? Well, you have the classification done by the group of Professor Kahn. And those classified into from 0 to a V-shaped, to a U-shaped, to an ultra U-shaped. In this case, we do have an intact bone. So we have the bone, and we also have occlusal control because we have teeth on both sides, and we have a bilateral stability in the occlusion. You could say that you could align all these teeth if that is, what you prefer, but the occlusion is good enough. So it's stable, and we can control it. So we sum up those factors, and we see that we have a green light basically on all of them. There we go. The green comes. We have a teeth position that's important for the patient. We have a gingival margin that's favorable. We have buccal bone. We have a good position, class 1. We have the possibility of obtaining primary stability, given that we know how to do it. And there's definitely occlusal control. The next analysis that we would do in these cases is the aesthetic risk assessment, which you will find from the ITI sites. And it's important. I think this risk assessment is much more important for the patient perspective than us. It's important that the patient understands if there is challenges in obtaining the correct aesthetic result after the treatment. And in this colleague, there's one red, and there's a lot of greens, and there is some oranges. And that's a good one. And so we go on, and then we make our choices. So I've greened out a lot of the factors that was necessary to perform this treatment, and then I need to make choices. Do I go for an extraction and an early insertion or implant placement? Do I go for delayed implant placement, or do I go for immediate placement? And if I go for some of these choices, do I go for early loading, delayed loading, conventional loading, or immediate loading? And in my opinion, in these cases, my choice as a default choice with all cases until the opposite is proven is immediate. And there's a lot of reasons why not to do it, but you need to prove why not to do it before starting the other way. Because from the patient perspective, an immediate treatment will give a much more convenient treatment travel for the patient. What do I need then to provide these immediate solutions? It's not enough to have a patient. I need a lot more, and I need the companies, the industry, everybody to support us with refinements. We're now in Straumann Corporate Symposium. Straumann did not invent fully tapered implants. Straumann for sure did not invent immediate treatment protocols. It's been on the market for years. But what Straumann did with the new thing they introduced is refining it. building experience on their own system and looking what's the trend in the market, what do we need? And if you look upon that, we now have an implant design that gives us the possibility of adapt a drill protocol for primary stability in each case. We also got instruments in the cassette to do more advanced procedures. It's small things, but if you work clinically, you know that we need these small things. And also the connection, there's finally a pickup of an implant within this system. That's important because if we're going to actively insert an implant with a little bit more forces than we used to, we need a direct pickup of the implant. And to do so, we also need the toughest materials on the market to not fracture the implant when we are doing these procedures. And we also need a surface that will guarantee us not only primary stability, but also a predictable secondary stability that will develop due to a surface technology. Prosthetically, we need components. The worst thing that happens in the market is when somebody introduces a design of an implant without prosthetic connections or prosthetic components. And that has happened. If you've been in this market like me for 20 years, you know that it has happened very often. So what we need is prosthetic components as they launch the implant. What we also need is instruments to do is chairside, because it needs to be predictable to do these restorations chairside. We need it to be easy to adapt for a digital workflow. We need biomaterials because we need that in the aesthetic zone to provide predictable aesthetics. And in my experience, placing an implant surgically in an extraction socket takes me about this time. Doing the restorative temporization of the patient takes this time. So basically, it's time to do it on the prosthetic face. And you need to plan for that in your, in your schedule, in your logistics. So I click off on my colleague, basically all boxes green. It's a good case. So on a case selection-wise, I'm happy and lucky with my colleague. Everything's green. So let's see how we apply this information into going digital. We use the cone beam CT to plan in different softwares. For these cases, we use the co-diagnostics. And we also use the intraoral scanning by 3Shape, which in my opinion is the market leader in this. And then we combine this information in obtaining enough surgical and prosthetic information to provide a predictable both surgical procedure, but also a temporary prosthetic procedure. We need to plan, and if you know how a axis of a root goes into the jaw compared to where you're supposed to place your implant, this is basically the most important information that you can have in these cases, because you cannot follow the axis of the root. We're not placing implants in extraction sockets. We're placing them outside of the extraction sockets. We're placing them centrally, palatally. We're trying to find bone. We're not anchoring something in an empty space. With this information, we have the dental lab. Our lab will then make it what should be a shell for a temporary restoration. And you will see how it has wings. It's called the temp shell technique. It's done by others also. It just rests on the neighboring teeth to make sure that we will have this in the correct position. This temporary restoration will then be used during and after surgery. And this is just a minute video of the surgical procedure that we do minimally invasive. As we cut away some of the fibers, we do a careful extraction of the tooth. We use the pilot drill or the needle drill or the precision drill. So we don't use these round burrs anymore to make the opening in the cortical. And then you will find the same colors. If you're a Straumann user, you will recommend the 2.2 is the blue one, 2.8 is the yellow one. And then in this case, we will finish off with the new color. If you haven't seen it, if you're a traditional Straumann user, is a white one, is 3.2. And then we will, with a surgical screwdriver, and it's basically this big, manually insert the implant because we will be changing a little bit on the axis of the implant to enter the palatal bone before we angulate the implant up. The same procedure we did with the drills. And when we have the position of the implant on the palatal, which you will see focused during the whole afternoon now, and then we have what we call slowly resorbable biomaterials. It's xenografts, and those will keep the volume of what is the aesthetic profile of the soft tissue. And you'll see also now a resorbable collagen sponge just put on top just to keep like my prosthetic and restorative colleagues away from my bone. So that one's just a protective one. And it's nice that Straumann now developed these nice surgical instruments, even to pack biomaterials. So it's small refinements, but it helps in the clinic and it helps in daily work. So that's the case when it's done surgically, and then we move the patient or my colleague now into another office. And then we will start working on the temporary. And then the temp shell will then be produced pre-op by the lab, looking like this in acrylic or PMMA or whatever material you would like. It's just important that it has some opacity. It needs to be not that translucent, because then it will be grayish. And then we transform these. We do a pickup on the temporary abutments, in which temporary abutments we can pick different gingival heights. So we have narrow gingival heights coming in specific heights, so we don't push away the bone or don't touch anything. And that's another refinement that comes with the system. And that one is then adapted. It's done with the screw access hole. And then we pick it up, we refine it, and then we torque it in to about 15 to 20 Newton centimeters as a temporary crown. So choosing the correct temporary abutment is important. Emergence profile design, and there's no contacts in occlusion or articulation of these. They're non-loaded. They're just temporized. So let's look at how this worked out. This is my colleague's smile, same-day smile. And this is from day 0, 6 weeks control, and at 12 weeks when the final restoration is inserted. Bone is still there. Okay, it's 12 weeks, but this is the same protocol we've been using since 2007 with different implant systems. And recently, during the last more or less 2 years, also now with the Straumann BLX system. So, what consequences does that have for my colleague? Well, it offers fewer visits. Okay, she's in my office every day, so that doesn't count. There's fewer surgical intervention, that counts. Less discomfort, that counts. Fixed tooth all the time, that counts. And more efficient treatment. And for me, as the employer of this colleague, it's less time away from work. Of course, it offers something. If I can provide minimal, the same result as I did when I did it conventionally, of course I should choose this. So, finishing off this one, I'd like to just give you some take-home messages. And those will be basically the same thing that I would traditionally say in my first slide. We do have primary goals and secondary goals of implant treatment. We should never try to risk the primary goals of successful outcome, high predictability, long-term stability, and low complication rate. But we should still try to challenge ourselves, providing more of the secondary goals to the patients. And that is the fewest possible numbers of surgery, low pain and morbidity during healing, short healing periods, and short overall treatment time. And summing that up, in my experience, immediate implant protocols offers great opportunities to achieve these results. But you also need to develop knowledge and clinical skills to do these procedures. Otherwise, the risk is too high. If anybody would like to get any of the information, any slides, anything that you need, please feel free to contact me by email. You will have it here. And I wish you, from this time on, a very nice afternoon with the rest of my distinguished colleagues that will be coming in this area. And remember, we are in Lisbon, so please also enjoy. It's important. Thank you for your attention.